So both has a rich experience in their field. So in this session, we are going to welcoming both of them. And the first session, I'm going to invite special thanks to Dr. Devanti ma'am for his session on reaching new heights in the MHSPC care. So welcome, Dr. Devanti ma'am. Is ma'am is there? Hello.
Yeah, thank you.
Yeah.
Thank you for inviting me. Please share the slides from your end.
Okay. Ma'am, if you can, I'm going to sharing the slides.
Yeah,
If any difficulty, so just let me know and kindly during the session, if you kindly on your camera, I'm going to sharing the slides.
okay, sure. Thank you.
Yeah, yeah. Hope my screen is visible, ma'am.
Yeah, it's
Oh,
visible.
okay. Just wait a minute. Hope it is visible, ma'am.
Yeah, it's visible.
Okay, okay. We are going to start now.
Am I audible?
Yes, yes. Audible, ma'am. Very much audible and visible also. Thank you.
There is some technical glitches from my.
Maybe no issue. No issue, ma'am. Just let me know. This is the first slide.
Yeah,
So if you
I know, but I want to share that I have to share. I have to be online from
okay,
another ID. Okay, it's not my ID. Okay.
okay. Got it, ma'am.
It's visible as Dr. Shubhankar Chakraborty.
It's
I
right. It's showing that actually.
Yeah, yeah. Okay.
No issue, ma'am. Just you can
Okay.
start your.
Thank you.
I have started this. When you are going to instruct me, I will go for the further pages.
Yeah. So today our topic of discussion is reaching new heights in metastatic hormone sensitive prostate cancer. Next slide, please. So thank you to Bayer Oncology for providing the academics as help by the slides. Next slide, please. So, if we see the prostate cancer landscape, it's very important because the prostate cancer can be diagnosed, and throughout the whole treatment period, prostate cancer can be diagnosed or it can be progressed to several stages. It is in locally advanced or localized stage, or there may be the newly diagnosed metastatic hormone sensitive prostate cancer, or even after the treatment of the metastatic newly diagnosed prostate hormone sensitive prostate cancer, it may progress to the non metastatic castration resistant prostate cancer, or another end of the prostate cancer is the non metastatic castration resistant prostate cancer. So the castration-resistant prostate cancer means even after the testosterone is in the normal level or below castration level, the disease is progressing. Either there is biochemical progression or there is progression via imaging. So even after, if the disease reached at the metastatic castration-resistant prostate cancer stage, the even after the best possible treatment, the OS benefit is not so much, and the terminal stage is the death. So our aim is to control the disease in the early stage or even in the newly diagnosed metastatic or non-metastatic hormone-sensitive prostate cancer stage. Next slide, please. So, as I told, the newly diagnosed metastatic hormone-sensitive prostate cancer is the or primary progressive metastatic hormone-sensitive prostate cancer. These stages they give the opportunity to delay to the progression to the metastatic castration-resistant prostate cancer, and it improves the outcome. Next slide, please. So, if there are several studies, if the newly diagnosed metastatic prostate cancer, next slide, please. Several therapy have been used. Next slide. In the low volume disease or the high volume disease, like low volume means if the metastasis is less than 4 bone metastasis, and high volume disease means if there is more than 4 bone metastasis, or including one non-vertebral bone metastasis, or if there is any visceral metastasis. And several therapy have been tried in these stages, from chemotherapy or the abiraterone, enzalutamide, and the apalutamide, and newly the darolutamide. And our main aim is the improvement of the overall survival. Next slide, please. So, outcomes with the several systemic therapy, and several systemic therapy have been tried in several trials, like in 2013, in GETAC trial, docetaxel was compared with the placebo, and overall survival, there was hazard ratio was 0.88. And then there are several trial like STAMPED trial, abiraterone, then Latitude, abiraterone, Arches trial, enzalutamide, and recently the Titan trial in 2019, the apalutamide was compared with the placebo in hormone-sensitive prostate cancer, and then the enzalutamide trial, Enjamid trial, where enzalutamide were compared, and here there was also benefit, survival benefit. And latest, the PEACE-1 trial, it is an important trial. Here, abiraterone was compared, abiraterone plus chemotherapy plus androgen deprivation therapy was compared with the non-abiraterone containing arm. Means standard of care means chemotherapy plus androgen deprivation therapy. And here there was overall survival benefit. And latest is the ARASENS trial, 2022. Here, darolutamide plus docetaxel was compared with docetaxel. And in both the arms, androgen deprivation therapy was given. And here, there was also overall survival benefit. And as we know, the darolutamide is also approved and beneficial in the hormone castration-resistant prostate cancer also. But in the newly diagnosed or metastatic hormone-sensitive prostate cancer, ARASENS trial is an important landmark. Next slide, please. So, if we see the docetaxel in the metastatic hormone-sensitive prostate cancer, if we see the overall survival in high volume disease and the low volume disease. And in high volume disease, the docetaxel plus androgen deprivation therapy or the ADT alone. Here, there is overall survival benefit was around 17 months, where the median OS was 51.2 months in the docetaxel containing arm, where it was 34.4 months in the ADT alone arm. And here the hazard ratio was 0.63. But in the low volume disease, docetaxel with ADT did not provide any extra benefit in OS in comparison with ADT alone. Next slide, please. And abiraterone was the first drug that showed that hormone treatment can be effective. However, it is important to understand the treatment journey of the control arm, because the control arm, they also have several drugs after placebo, and when interpreting the data, it also somehow affects the result. Next slide, please. And now prednisolone with abiraterone, and with abiraterone arm, there are several side effects like hypertension and dyselectrolytemia like hypokalemia, or there may be hepatotoxicity. And like in grade 3, the hypertension was 22% in abiraterone plus ADT plus prednisolone arm, where grade 3 hypertension was only 10% in ADT plus placebo arm. And another important side effect of abiraterone is fluid retention. And another hypokalemia, dyselectrolytemia, grade 3 dyselectrolytemia, it was 11% in abiraterone containing arm, where it was almost 1% in the ADT plus placebo arm. Next slide, please. Another drug, apalutamide plus ADT versus placebo plus ADT, as per the Titan trial. And here the overall survival benefit was, the hazard ratio was 0.48 in case of PFS, and in OS it was 0.65, but the p-value was 0.0001. And in the subgroup analysis, the hazard ratio was 0.36 in the low volume disease, where in the high volume disease, it was 0.53. Next slide, please. And another drug like enzalutamide plus ADT versus NSAA plus ADT. Here the hazard ratio for clinical progression-free survival was 0.40 and OS was 0.67. And here also subgroup analysis of the OS was done in the low volume disease and the high volume disease, where in low volume disease, the ratio was 0.43 and in high volume, it was 0.8. Next slide, please. So as we told, in the hormone sensitive prostate cancer, our aim is to combine all therapy to improve the outcome, to improve the OS, and to improve the progression-free survival, and to delay the progression to castration-resistant stage. Next slide, please. And now coming to the drug of our today's discussion. And here the study period was November 2013 to 2018. Here the metastatic hormone sensitive prostate cancer, total number of patients was around 1200, and de novo M1 disease was included, and but prior chemotherapy or recurrent metastatic disease was not included in the study. Performance status, as per the performance status, and disease volume, high volume or low volume, and other inclusion criteria was less than 3 months of ADT prior to randomization, and as stratified as per the ECOG-PS and metastatic site like lymph node, non-regional lymph nodal metastasis, that is M1, or any bone metastasis, or any visceral metastasis, or visceral metastasis with or without bone metastasis, or type of castration, whether it is by orchiectomy or medical castration by LHRH agonist versus LHRH antagonist, and docetaxel, and number of docetaxel received. And here two groups were there, arm A, standard of care, and arm C, and pooled arm 1, arm A, standard of care, and arm C, standard of care plus radiotherapy. And next, arm B, pooled abiraterone group, arm B, standard of care plus abiraterone plus prednisolone, and arm D was standard of care plus abiraterone plus prednisolone and radiotherapy. Next slide. So if we see the high volume disease and low volume disease, the difference between the OS, the median in the standard of care arm, and there was confirmation that in high volume disease, the improvement, there was obvious any benefit, obvious improvement of outcome by adding abiraterone with docetaxel versus docetaxel alone. And in low volume disease, the addition of abiraterone with docetaxel was not beneficial as the high volume disease. Next slide, please. Now coming to the our study, to our today's discussion, ARASENS trial, and it was a global randomized, double-blind and placebo-controlled phase 3 study. And here two arms are there: docetaxel plus darolutamide versus docetaxel plus placebo, and in both arms ADT was used. And total number of patients was 1306. Metastatic hormone sensitive prostate cancer, and ECOG POS was 0 or 1, and the stratification of the cases was as per the extent of disease, whether the disease was there was bone metastasis or non-regional lymph nodal metastasis or visceral metastasis with or without lymph nodal or bone metastasis, and baseline alkaline phosphatase level. And there are several other factors like the Gleason score, etc. And darolutamide was given as per the dose with 600 mg twice daily dose. And here the primary endpoint was overall survival, and secondary endpoint was time to castration-resistant prostate cancer. And another important is time to pain progression. Most of the prostate cancer in the advanced stage, they are very painful. So time to pain progression was one of the important secondary end points. And symptomatic skeletal event-free survival, and time to first symptomatic skeletal event, and time to initiation of subsequent antineoplastic therapy, and time to worsening of physical symptom, and time to initiation of the opioid use, and most obviously last but not the least, safety and quality of life and safety. Next slide. So if we see the overall survival by the Kaplan-Meier survival curve, there was obvious benefit of the there was obvious benefit by the addition of the darolutamide, where there was in the placebo group, the placebo group, the median OS was less than the darolutamide arm. And in the high risk patient, on the low risk patient, in the high risk patient, the hazard ratio was 0.71, and in the low risk patient, the hazard ratio was 0.62. And by improving the OS, there was one second. Sorry for the interruption. And
No issue, ma'am. It's okay.
and another in the there is obvious benefit by the addition of the darolutamide. Next slide, please. And if you see the secondary efficacy point, as we discussed, like the time to progression of the progression to the castration resistant, with addition of the darolutamide with the docetaxel and the ADT, there was obviously almost 64% risk reduction with addition of the darolutamide, where the hazard ratio was 0.36. And if we see another endpoint like time to the first subsequent anti-neoplastic therapy, there was 61% risk reduction. Time to pain progression, there was almost 21% risk reduction. And a time to first skeletal related event, there was also benefit, 20% risk reduction. Next slide, please. And if we see the PSA response and PSA outcome, and if we see the curve of the undetectable PSA at 36 weeks and detectable PSA at 36 weeks, the hazard ratio was 0.23, and we can conclude from this overall survival and the PSA value that more than 2/3 of the patient reached below the 0.2 in the overall study. Next slide. So darolutamide plus ADT plus docetaxel, this triplet achieved a long periods of no disease progression, and also there is significant improvement in the overall survival. Next slide. Next slide. So if we see in the metastatic hormone sensitive prostate cancer and usage of darolutamide containing triplet, first thing to decide whether the patient is able to tolerate and accept docetaxel and to complete 6 cycles of docetaxel, and the extent of disease, whether it is high volume disease or whether there is low high volume disease and disease extent. And another thing is age and life expectancy. The age and life expectancy of the patient is important factor, and these all and further therapy and molecular testing in case of disease progression, these things are important. Next slide. Another thing that is safety issue, like with the addition of the darolutamide with the docetaxel and ADT arm, there was no obvious increase of the side effect or adverse event. The adverse event which are visible in the study also, these are because of the chemotherapy part, and the patient who could tolerate the 6 cycles of docetaxel chemotherapy, there was no increased side effect because of the darolutamide in comparison with the placebo controlled arm. Thank you.
Thank you, ma'am. Thanks for your valuable time and for the nice presentation you have provided in consideration this prostate cancer session. And very much welcome going to our next session with welcome warm regards for Dr. Devapriya Mandal, sir, who is a senior consultant medical oncology from the Fortis Hospital, Kolkata, with a vast experience from previously as PMC Kolkata and Apollo Kolkata and other institutions also. We are going to congratulate and welcome Dr. Devapriya, sir. So very welcome, sir, for this nice session. So should I going to share the slides, sir?
Yes, please.
Okay, okay. Thank you, sir. Just a minute. Hope my screen is visible, sir.
Yes, yes.
Okay, just give me 1 minute. It is okay, sir? Visible?
Okay, okay, yes, okay.
Yeah, yeah. Thank you, sir, and welcoming for this session of this topic, advancing MHSPC treatment horizon, darolutamide without chemotherapy of Aranold evidence. Welcome, sir.
So thank you. We shall discuss about the one of the most important doublet option in metastatic hormone-sensitive prostate cancer with darolutamide and androgen deprivation therapy. So we'll discuss about the ARANOTE study. Next slide. So this is the statutory disclaimer. So the care of metastatic hormone-sensitive prostate cancer has evolved to combine androgen deprivation therapy with a host of other options. First to come in was docetaxel, and it was the STAMPEDE and CHARTED trials which established the role of docetaxel in 2015. After that came in abiraterone. Abiraterone again was tried in LATITUDE and STAMPEDE trials. Thereafter, there was enzalutamide in ARCHES, apalutamide Titan, Inzamate, another enzalutamide trial. And in 2021, we first saw that not 2 drugs, but 3 drugs could actually be also an option for patients with high volume disease. That was piece 1, abiraterone plus ADT plus docetaxel. And then we had Aracin, so another triplet option. However, there are subtle differences between Aracin and piece 1, which are very clinically important. And in 2024, we had a chemo-free option for darolutamide as well, with darolutamide plus ADT and darolutamide plus ADT in ARANOTE and ARASEC. So despite treatment with androgen deprivation therapy or ADT or docetaxel, a large proportion of them will progress to metastatic CRPC within the next 3 years. Next slide. So an unmet medical need remains for an efficacious treatment that offers differentiated and improved safety profile for patients with metastatic hormone-sensitive prostate cancer without adding significant toxicities and without a low drug-drug interaction. Aracin was a phase 3 study, and it's already approved, already shown clinical benefit and approved in India. So darolutamide plus ADT with docetaxel is a standard of care for metastatic hormone-sensitive prostate cancer. In Aracin, they looked at whether darolutamide plus ADT versus ADT could be a meaningful option, a treatment option for MHSPC without docetaxel. Next slide. So it is a randomized, double-blind, placebo-controlled phase 3 study. In that, patients were randomized 2:1 between darolutamide plus ADT or placebo plus ADT. The primary endpoint was radiologic PFS. The secondary endpoints were OS, time to initiation of subsequent therapy, time to CRPC, time to PSA progression, and many others. And the open label phase was done until final analysis. Open label for darolutamide and 100% crossover to open label darolutamide. And the selected endpoints were OS and safety. Next slide. So as we can see in darolutamide plus ADT and placebo plus ADT, the median age was 70, and most other, all other subsets were well represented. And if you look at it, it was well represented by high volume disease as well, with 70.6% of the patients having high volume of disease. Next slide. So it was a presentation across, all over the world. It was presented by Asian and American population. So Asian patients were 30%, Latin America 29%, Europe and rest of the world there are 40.1% patients. Next slide. These are more global than most other trials. Indian patients were there as well. In India, there were a good 61 patients. So you can see that this was well represented by Indian patients as well. Next slide. So darolutamide plus ADT significantly reduced the risk of progression or death by 46% versus placebo plus ADT. The median radiologic progression-free survival was not reached versus 25 months with placebo plus ADT. The hazard ratio, as you can see, was 0.54, and the median follow-up was a good 25.3 months in the darolutamide group. Next slide. So looking at the subgroup, we can see that patients with high volume disease, low volume disease, and most other important subgroups clinically benefited from this. The benefit was seen across all subgroups. Next slide. So if you look at the overall survival, then it was not reached. Only 23% of the patients had made the overall survival event compared to 26.9% in the placebo plus ADT arm. Time to metastatic CRPC was again not reached, and it was 13.8 months in the placebo arm, and time to PSA progression was 16.8 months in the placebo arm, and time to initiation of subsequent systemic therapy for prostate cancer was not reached. Time to prevent progression was 29.9 months versus not reached. So not reached for all the clinically meaningful endpoints in favor of darolutamide. The OS data remains immature. Next slide. So time to MCRPC and time to pain progression, you can see these are significantly better. So it delays the time to pain progression and time to metastatic CRPC in patients when there is darolutamide plus ADT. Next slide. So darolutamide plus ADT achieved a deep and durable PSA response. 62.6% of the patients reached PSA less than 0.2 nanogram per ml. And time to PSA progression, we can see, is not reached versus 16.8. So there is wide separation. Next slide. So the proportion of patients achieving undetectable PSA was much higher, even in the high volume disease subset. If you look at it, the darolutamide, there were at any time, there was 54.6% patients in high volume who achieved a undetectable PSA. It was as high as 82.6% in patients with a low volume disease. Next slide. So subsequent life prolonging anti-cancer therapy in darolutamide, 32.5% versus 42.5% in this placebo. So again, this is much less common in darolutamide showing benefit. Next slide. Treatment emergent adverse events were similar between treatment groups, and discontinuations were lower in the darolutamide arm. So this is very, very important to note that this is a drug which is so safe. The serious adverse events are so far and few that they are lower than placebo. So placebo plus ADT had more discontinuation than placebo plus darolutamide. So it says a lot about the safety and the very tolerable toxicity profile of this drug. Next slide. So common adverse events were low and similar between the treatment groups. And fatigue was common, although fatigue could be attributable to just androgen deprivation therapy itself. It doesn't say that fatigue can be attributable to darolutamide. Next slide. So treatments commonly, adverse events which are commonly related to androgen receptor pathway inhibitors, they were common and low in both the arms. Next slide. So darolutamide also confers a positive impact on health-related quality of life. It extended median time to deterioration in PAC-P total score by 5.1 months versus placebo. And darolutamide is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in pain progression and overall well-being. Next slide. So it's showing the time to deterioration in PAC-P subscale scores, which show that clearly darolutamide combination showed a much better profile. Next slide. So darolutamide plus ADT significantly improved radiological PFS in patients with MHSPC. This combination showed a benefit across all secondary endpoints. It was associated with a deep PSA response regardless of baseline PSA. Darolutamide is the first and only androgen receptor inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, and it has a very favorable safety profile. So darolutamide plus ADT without docetaxel, it is an additional standard of care for MHSPC. Next slide. So with that, I conclude this presentation. Thank you. I'll be happy if there is any question.
Thank you, sir. Thank you for your nice presentation. And with this, if anyone has any kind of questions or any clarity, then you can ask. Dr. Devapriya sir is here. So, is there any question from any side? I think, sir, no such questions there is. So, thank you, sir. We are going to conclude the session. And thank you for your nice presentation. Thank you for your valuable time, sir. Thank you, sir.
Good night.
Thank you. Good night, sir.
Should we close the session?
Yeah, I think we can close the session. Thank you. Thank you, sir.